A very good afternoon from Singapore. I would like to start by thanking the iVascular team for giving us this opportunity to present our 12-month data from the Merlion Trial from Singapore. These are my disclosures relevant to this talk. As an introduction, endovascular therapy has become the first-line choice for infrapopliteal arterial occlusion treatment in Singapore because it's minimally invasive, repeatable, and in the setting of CLTI in our patients have multiple comorbidities and generally do not prefer an open procedure. There is also a lack of surgical conduits because they're diabetic. However, the problem with endovascular therapy is that POBAR and bare metal stenting is plagued by vessel restenosis and recoil. And in the setting of our wounds, these wounds can take at least 3 to 6 months to heal. And therefore, you want to keep those vessels open as long as possible. The diabetic foot challenge in Singapore is mounting. The OECD data recently suggested that our major amputation rates are 4 times than that of the West, and is increasing because the diabetic prevalence is increasing too. So the Merlion trial was a physician-initiated, prospective, non-randomized, multi-center trial investigating the safety and efficacy of the treatment using the Luminor drug-coated balloon device and the Angiolite drug-eluting stent in the setting of chronic limb-threatening ischemia of TARC-C and TARC-TD, tibial occlusive disease. As a reminder, the Luminor balloon is a paclitaxel high-dose drug-coated balloon with a water-reducing ester excipient and unique nanotechnology spray technology to enhance the drug uptake into the arterial wall. The Angiolite BTK stent is a cobalt chromium stent, which is mounted with sirolimus, which has one of the higher radial resistive forces compared to their competitors. So the primary objective of this study was to evaluate the 12-month outcomes using these two devices, either in combination or alone. And we looked at only TARC-C and TARC-D tibial occlusive lesions. These were some of the study endpoints of interest, including safety, device or procedure-related mortality through 30 days. And we also looked at freedom from major target lower limb amputation and primary patency rates at both 6 and 12 months. We recruited from 2 sites, and we recruited 50 patients in total, the majority from Singapore General Hospital and 15 from Khoo Teck Puat Hospital. As an introduction, SGH normally performs over 1,200 lower limb angioplasties over the last 18 months for CLTI. The majority of our work is CLTI as opposed to claudication. Our patients usually present late. More than 90% are diabetics, and more than 50% have some degree of renal impairment, and the disease is generally multi-level in nature. These were the inclusion criteria. We only included Rutherford scores 4 to 6, TARC-C or D lesions, as I said, and there had to be at least 1 vessel runoff to the foot. This was the flow chart of the study, and we only included the patients at having done the angiogram, and we followed these patients prospectively at 1, 6, and 12 months. Turning to patient demographics, you can see these were quite frail patients with a high load of diabetics, 94%, and 50% had end-stage renal failure and on hemodialysis. Turning to procedural information, you can see that more than 50% of these cases had moderate to severely calcified lesions. 82% of these patients had a Rutherford 5 classification. Nearly 50% of these patients had a long duration of symptoms, more than 3 months. We only, though, performed 3 bailout stentings for residual dissection or persistent recoil. So turning to Rutherford classification change, you can see that there was an improvement by at least 1 category in about 60% of cases. In terms of treatment outcomes, you can see at 12 months that the target lesion primary patency was around 70%. There was a freedom from TLR of about 82%, and a major amputation-free survival of about 74%. It is important to note that there was a symptomology improvement in about 65% of patients, And in about 2/3 of these patients, the index wound had healed completely by the end of 1 year. This is an example of a Merlion case study, a 52-year-old Indian male presenting with a 1-month history of 4th and 5th toe gangrene. You can see he's got a full house almost of peripheral artery disease risk factors. The target vessel in this case was the anterior tibial artery. The lesion was a TAR C lesion with long 70% multifocal stenosis. This was treated successfully with three 150 millimeter length luminol drug-coated balloons with a residual stenosis of less than 30% at the end. As you can see from the follow-up duplex scans, the anterior tibial artery was still open at 12 months. And you can see the wound healed pretty quickly within 3 months and stayed healed at 12 months. So, in conclusion, ladies and gentlemen, the treatment of long tibio-occlusive lesions in the setting of CLTI is pretty successful using this device. We included a highly frail population of patients from 2 centers. There was a 100% technical success rate. There was an excellent safety profile. The 12-month amputation-free survival was 74%. It was efficacious. The target lesion primary patency was around 70%, and freedom from TLR was about 82% at 12 months. We achieved a total wound closure in about 2/3 of these patients, and there was at least improvement of 1 Rutherford category in about 60% of these patients. And in that, I hand you back to the chairman, and thank you very much for listening. I would like to acknowledge my good friend, Dr. Leong, for his collaboration from Khoo Teck Puat Hospital, for this study would not have been possible. Thank you very much for listening.